Start the stream now. Hey, just give me just a sec here, guys. Sorry. This is the part. To make
Should I
sure.
take the slide down and make sure there's not something on the computer playing?
I would.
I don't hear anything.
We don't hear anything.
There's no sound.
I'm getting.
What are you hearing?
No, I'm getting.
Oh, you're hearing it from YouTube.
Yeah.
Just turn that,
Turn it off.
close that tab.
Where's the YouTube tab at?
It just automatically opens when we do restream. Sorry about that.
Here.
Yeah.
Oh, no.
Better?
Oh, no.
They can hear it. They can hear it. We can hear it in the room.
Yeah. Okay.
It's playing in the room.
Better?
I apologize for the delay.
Technical difficulties.
This is the part where I will get to say.
There it is.
Okay. For the third time this morning, no battle plan, no matter how well conceived, ever survives first contact with him. So that's what we're dealing with. We had a great plan.
All right.
And now the internet is.
Three, two.
Welcome, everyone. Welcome to everyone who's here in person and to everyone who is here online joining us to talk about CLL. The name of this program is Let's Talk CLL. Many of us, all of us, are on some portion of a journey with chronic lymphocytic leukemia. My name is Jeff Folliter. I am a passionate patient advocate. I do this often and I do this passionately because I really do want everyone to know that it is not just possible to live a good life with CLL, it's possible to live a great life with CLL. A little over 13 years ago, my first doctor diagnosed me with CLL. And in a very brusque way, he informed me that I should expect 6 years to live. Sounds fun, right? I fired him. I wound up here at MD Anderson, and my doctor at the time, Dr. Michael Keating, picked me up out of the chair, gave me a big giant hug, and he said, "You're going to die with this, not from this." And that felt really, really good. A couple of months ago, I had the honor to speak at his retirement gala, and he pulled me off to the side and he says, I'm changing my mind. We're going to cure you. That had a lot of gravity. It really did have a lot of gravity. So why do I think that it's possible to live a great life even with a CLL diagnosis? The reason is I am absolutely doing everything that I want to do with my life, and not just at a low level, at a really loud volume level. I'm a better father. I'm a better husband. I'm a better friend. I am doing everything that people who don't even have a cancer diagnosis could even dream about doing. Right now, I am training to do the Bataan Death March Memorial Marathon in March. It's held in the high desert of New Mexico. I'll be over a mile up, doing 26.2 miles off-road because it's fun. I pound out the miles every morning. I love doing it. Do I have a typical CLL patient fatigue situation? You betcha, except mine's self-inflicted. Now this guy over here, that's my doctor right now, Dr. Wierda. Every time I come in and see him, he asks me why I worry so much. I shouldn't worry. I do. I understand it. We're going to talk about some of that stuff today. I want to thank our sponsors, AbbVie and Beijing. I want to remind each and every one of you that what's happening in this program is not medical advice. You're here to learn about what's happening. Anything specific about your condition, what is happening with your treatment should be discussed with your doctor. We welcome questions. Send in your questions to community@thepatientstory.com. Now, here's the part where I have to be Mr. Corporate Guy. At the end of this presentation, there is going to be a survey. There is always a survey. I am begging each and every one of you, both here and online, please answer that survey and answer it candidly. We use the responses from those surveys to make sure that we're delivering the content that you want to hear, that is important to you, and that makes a difference in your life. So now we get to meet a couple of rock stars. I'm going to have a seat now. Joining us on our panel today is Dr. William Wierda from MD Anderson Cancer Center, Dr. Nicole Lamanna, Columbia University Medical Center, Dr. Adam Kittai from the Ohio State Comprehensive Cancer Center, and Dr. Jackie Broadway-Duren from MD Anderson Cancer Center as well. I'm going to start with you, Dr. Wierda. I need 2 bullet points. Why CLL? Why is CLL your focus and passion?
Because my background is in immunology, and I have a Ph.D. in immunology. I've always been interested in immunology. CLL is a unique disease from an immunologic perspective. And as a fellow, I was working with Tom Kipps at UCSD and trained with him and was doing immune-based treatment strategies. And that's more than 2 bullets, but that was the beginnings of my interest in CLL and why I have stuck with CLL for many years. And then Michael Keating recruited me to Anderson, and I think most everybody knows Michael Keating and what a
yes, how can you
bigger than life person he is, and really somebody who's inspired me many years with my work in CLL.
Thank you. Dr. Lamanna, you get 2.5 bullets as well.
Well, Michael's also been a mentor of mine for years too. But I enjoyed taking care of the whole patient, and so I was inspired by leukemia mentors at Memorial Sloan Kettering when I was an intern and a resident, and because of that sort of aspect of handling the entire patient, acute leukemia and leukemia in general became a passion of mine, and so I wound up going there and doing my fellowship and staying in leukemia ever since. So chronic lymphocytic leukemia affects all, not just the blood problems, but your whole body and many different organ systems and your immune dysfunction. And so I like handling the whole patient, and that's why I've stayed in CLL.
I'm also noticing your accent. East Texas? Dr. Kittai.
Yeah, no, I really enjoy seeing my patients longitudinally over time. And so with CLL, as you had brought up before, it's a disease our patients live with for a really long time. And so it's a pleasure for me to get to know my patients, get to know about their families, and really see them over the course of their lifetime.
Dr. Jackie, you've put up with me for well over a decade in clinic. So I really want to know, why CLL?
Well, actually, because Dr. Keating recruited me to work with him, with his CLL team. When I first came to MD Anderson, I worked with acute leukemias, and it just became so emotionally overwhelming for me. And so he seized the opportunity to ask me to work with his team. Since that time, as others have stated, the CLL patients are very unique. You get to follow them for a long time. You get to know their families, become a part of their families. And most importantly, this is the leukemia that has some of the most exciting treatments that are currently available and on the horizon. So that's why I stay with CLL.
It's almost as if I scripted this. That's the perfect segue. I'll start with you, Dr. Wierda. The overview of current CLL treatment options. When I first started this,
Wow.
there was basically one choice. What's happened?
What's happened has been, in the last 10, 15 years, the evolution of targeted therapy for patients with CLL, where we've developed these oral agents that are extremely effective at controlling the disease, i.e. the BTK inhibitors, and then also development of venetoclax, which is a BCL2 inhibitor, also an oral drug, that are highly effective, very well tolerated treatments, and have really changed the natural history of the disease and have really impacted on survival for our patients, and now what we're working on is sort of optimizing how to use those and how to work with them to develop curative therapy. So the landscape has changed remarkably over the last 10, 15 years, where now we're really not giving chemotherapy anymore. And it used to be the standard treatment. And we have highly effective treatments that are very well tolerated.
That sounds great, but Dr. Lamanna, help me understand. I mean, chemo had been around forever. Have we kind of left it in the dust on purpose?
No. I mean, the regimens like fludarabine, cyclophosphamide, and rituximab, or FCR, which Dr. Keating championed, were very effective regimens. It's just that, they had a whole host of side effects with them and were less targeted. And now we have more focused, better therapies that have less side effects, deal with the biology more precisely. And so we've moved away from chemoimmunotherapy, as Dr. Wierda alluded to. Now, there are obviously patients who might be in different parts of the world that still get these therapies because they may not have access to these agents. So we don't want to say that, it's other places they may still need to use them because, they may have less access. But we've moved away from it because now we have more effective, less toxic therapies available to us.
Dr. Kittai, there is a slide up on the screen right now with a whole bunch of words that for most of us are really, really difficult to pronounce. Can you tell us what's going on with these targeted therapies? What are they doing and why are they so important to CLL patients today?
So I'll start with the easiest. So underneath the Bruton's tyrosine kinase inhibitors, if you look at the words that are in parentheses, ibrutinib, acalabrutinib, and zanubrutinib, those are the generic names for the drugs. And they all end in brutinib. And that's because they all target Bruton's tyrosine kinase. So that's a way of memorizing what they do. Bruton's tyrosine kinase is an essential messaging protein that allows the CLL cells to survive. And these three drugs target that Bruton's tyrosine kinase and prevent it from working. So it's an essential pathway within the B cell receptor that activates the CLL cells. And so these inhibit that specific protein to prevent the CLL cells from dividing and living a long time. And so that's how you kind of remember those three drugs. The generic names are, the brand names are a little bit more confusing: Imbruvica, Calquence, Brukinsa. Not really sure how to memorize it that way, but at least in terms of the generic names, the Brutinib tells you what it does. BCL2 inhibitors, currently the only one approved is venetoclax or Venclexta. And how I describe this to my patients is that cancer cells like to increase signals that allow them to live longer and avoid dying. And our mitochondria, and as we all learned in basic biology, is the powerhouse of the cell, as I like to say, have these two balances that live on top of it. And there's the pro I'm going to die balance and the pro I'm going to live balance within the mitochondria. And so what cancer cells like to do is they like to increase the we're going to live balance on the mitochondria. And what the venetoclax does, it corrects that and increases the we're going to die balance on the mitochondria. So in a way, what this does is it basically leads to an equilibrium improvement for our CLL cells, allowing for the drug to work and also treat the CLL. The PI3K inhibitors, Zidelig, idelalisib, we're not really using this as much anymore as we used to. They also impact the B cell receptor pathway, which is another way that the CLL cells divide, that the Bruton tyrosine kinase inhibitors do the same thing. So the PI3K inhibitors work very similarly to the Bruton tyrosine kinase inhibitors, but a different molecule altogether.
So Dr. Broadway,
Yes.
you've been watching patients go through this evolution. They started off with very narrow choices, and then we revolutionized things with FCR and similar treatments, and now we're moving on to targeted therapies. Every time I saw you, you were the boots on the ground with me. You had the pulse of the patient. How are patients responding to this new mode?
Well, the patients are absolutely loving the oral therapies. Many of them now have reported feeling like they can play golf for the first time in years because they have that flexibility now because these medications are taken at home. And so it frees them up to do more activities of daily living, as you alluded to in the beginning. No one wants to sit in a chair for hours and take chemotherapy, nor do they want to deal with the side effects of chemotherapy. So I clearly remember when ibrutinib was about to be approved, and we were anxiously awaiting the approval of ibrutinib. And when we had phone calls months ahead of time when people wanted to be on the first studies that we had for ibrutinib. And it has definitely revolutionized the care for CLL. Now, these drugs are not without side effects, but they are tolerable, and they are side effects that we can work through with the patient. So it takes a multidisciplinary approach, but this is certainly a better option for patients than chemotherapy.
I'm taking a deep breath because I'm currently in watch and wait again. Again, I started off over 13 years ago, did the watch and wait thing. And I know you can't stand that term. We're going to give you a chance to talk, Dr. Lamanna, I promise. I went through a clinical trial here at MD Anderson where I used a single agent immunotherapy drug. And although that drug is no longer frontline, other immunotherapy drugs are still being paired with some of these new treatments. So Dr. Wierda, tell us about the Alpine trial, the Elevate trial. What's going on with combining like zanubrutinib versus ibrutinib and acalabrutinib versus ibrutinib and getting these involved with obinutuzumab and things like that? What's going on there?
So the Alpine trial and the Elevate trial, those are what we refer to as randomized phase 3 clinical trials.
Okay.
Those are to look at one BTK inhibitor versus another. Both of those trials compare a second generation BTK inhibitor against ibrutinib, which is the first generation BTK inhibitor. And so those trials demonstrated an improvement in tolerability with the second generation BTK inhibitors over what has been the standard long-term, which is ibrutinib. There's a bit more cardiac toxicities with ibrutinib compared to the second generations. And so those trials are phase 3 trials comparing two treatments and showing that the tolerability and the toxicity is a bit less. with the second generation inhibitors compared to ibrutinib. There's some suggestion that zanubrutinib on the Alpine trial may have a better progression, what's called progression-free survival. But the follow-up is different for those trials. The patient population is different from those trials. Clearly, they demonstrate that the second generations are preferred treatments over the first generation, but I don't think you can make any conclusions between the different second generation BTK inhibitors, acalabrutinib versus zanubrutinib. So that's those trials. There are other trials that are phase 3 randomized trials comparing different treatments. Some of them are like Illuminate. Those are all trials that have looked at chemoimmunotherapy, what has been the standard long-term, versus targeted therapy. And they're predominantly BTK inhibitor-based treatments and predominantly first generation and second generation BTK inhibitors. So there's a number of those trials that have clearly shown improvement in progression-free survival with these oral BTK inhibitors over chemoimmunotherapy. And a couple of the trials have shown survival advantage if you start with a targeted therapy. So what you're referring to are a lot of different trials that are phase 3 trials that compare different treatments and work to show benefit for a particular treatment over what has been the standard.
Dr. Lamanna, we have a question that's come in, and I think the question's going to work perfectly with this bullet on my list here. One of the things that's been combined is ibrutinib with venetoclax. Does it work? Does it work well? More importantly, Kim B wants to know, why is it approved in Europe and not the USA?
Oh, boy.
Sorry.
Yes. So there's a move, as Bill alluded to, there's been lots of studies that have shown the benefit of these agents over chemoimmunotherapy. And now we're trying to look at different sort of combinations to see if we can tweak these therapies better. And so there are now combinations of the BTK inhibitors plus venetoclax, so oral combinations. And so there are many trials that are looking at whether it be ibrutinib and venetoclax or acalabrutinib and venetoclax or even zanubrutinib and venetoclax. And there was a study in Europe called the GLOW study that looked at ibrutinib and venetoclax versus more traditional chemoimmunotherapy with chlorambucil and obinutuzumab. And there was obviously, chlorambucil and obinutuzumab is a regimen that's not typically used as much here in the US anymore, but was sort of a gold standard for older, frailer patients with CLL. As a standard chemoimmunotherapy regimen. And so nobody was doubting that the ibrutinib venetoclax arm would be better. I don't think that was a surprise for anybody. And so this got approved, this study based on the combination of ibrutinib and venetoclax in Europe from this GLOW phase 3 randomized study, as Dr. Wierda suggested. So against standard of care, this was approved as a regimen that can be given in Europe. There were some toxicities from this regimen. And so our regulatory, where there are different regulatory boards here versus in Europe, our regulatory boards, I think, want us to look at some of the newer generations, acalabrutinib or zanubrutinib with the oral combinations in some of our phase 3 studies before this oral combination gets approved. So ibrutinib and venetoclax is not approved here in the US.
Yet.
I think that because of what Dr. Wierda said before, because of those head-to-head studies of ibrutinib versus acalabrutinib or ibrutinib versus zanubrutinib, because the newer generations of these BTK inhibitors have less cardiac toxicities, even though ibrutinib is a great drug, the class is a great class, has done really well for our patients. The newer generations have less side effects. And so because of that, partnering with a newer agent that may have less toxicity for our patients is probably where the FDA is going to want us to go versus with ibrutinib.
So I'm going to try to play back what I think I've heard so far to you, Dr. Kittai. We started off with treatment programs that were kind of broad brushes. They tended to wipe out a whole lot of things with a big broad brush. And now what we've done with these trials and with these trials that I'd like you to talk about, we're narrowing the focus. So instead of just treating all CLL patients with one regimen, now we're really paying attention to, okay, what kind of CLL are we talking about here? And what's the best personalized care? Is that a fair statement?
I think that's a totally fair statement. So, one of the things that we haven't touched on yet is that we don't know if the BTK inhibitors are better than venetoclax plus obinutuzumab. There hasn't been a randomized phase 3 trial to tell us that this approach with time-limited therapy is better than continuous therapy. And so if we don't know which way is better, ultimately it comes down to a lot of different things that is really patient-focused, right? So some of it's comorbidity, and some of it's the risk of the CLL that helps us make that determination. But I think one of the biggest things that helps me decide what to give my patient is my patient. So a lot of times when we're talking about time limit therapy versus continuous therapy, a lot of our patients have a specific want to go on one of those options. And ultimately it comes down to a conversation of the pluses and minuses of each regimen, which certainly is patient specific and patient focused. So, for instance, the continuous therapies are generally very well tolerated. Generally, after I start a BTK inhibitor, I see my patients 2 weeks later to make sure everything's okay, 1 month after that, and then every 3 months after that. So it's a really easy startup. Whereas the venetoclax plus obinutuzumab time-limited therapy, the patient has to come into clinic basically weekly for the first 2 months. We have to do a little bit more monitoring where we have to watch the cell counts because the cell counts can get a little low, but everybody gets a stop after a year. And so, if you have someone who is a younger person who has an active lifestyle, who really can't get off work to come into the clinic once a week for that regimen, they may opt for continuous therapy. Whereas in a similar person, same person, right, who's a younger patient who just can't see themselves taking a pill for so long, they may opt for time-limited therapy because it's just they want to get it done with, right? So each patient's different. And now that we have all these different options, we have a lot of different options to use for our specific patient in front of us.
So let's talk about some of these clinical trials, which are giving us even more options. We've got the CLL-17 trial, the Alliance trial, and pirtobrutinib there. I think I got through that. There's a couple of trials going on there. And one of the things that I noticed, and it was an echo from what I heard from you this morning, Dr. Lamanna, we're not talking about pairing things. Now we're talking about triplets as well. So tell us what's going on here and why patients need to be aware of what's going on.
Yeah, so I had said before that the BTK inhibitors haven't really been compared to time-limited therapy to tell us what to pick and which is better. So that's why all of us are really excited about the CLL-17 trial. So this is a randomized phase 3 trial that's comparing continuous ibrutinib versus time-limited venetoclax plus obinutuzumab versus time-limited ibrutinib plus venetoclax. So hopefully we'll have a better understanding of which way to go for our patients in terms of what might be the most efficacious and safe option here, because we really don't know how this trial is going to plan out. So as Dr. Lamanna had alluded to, when we had thought of the GLOW trial, we were pretty sure that ibrutinib plus venetoclax would be chlorambucil plus obinutuzumab. Here on the CLL-17 study, I honestly don't know. I have a thought maybe, but I honestly don't know how it's going to go. So we're really excited to see how that trial goes, and it's going to be some years before we actually find out, unfortunately. The Alliance trial here is ibrutinib plus obinutuzumab versus ibrutinib plus obinutuzumab plus venetoclax. And the preliminary, so the triplet, right, ibrutinib, venetoclax, obinutuzumab versus ibrutinib plus obinutuzumab. And similarly, a lot of us had thought that the ibrutinib, venetoclax, obinutuzumab combination probably was going to be more toxic than the ibrutinib plus obinutuzumab, because in general, when you add more drugs to a regimen, the toxicity generally increases. So we were expecting that. But with a time-limited therapy, maybe the toxicity outweighs the efficacy benefit that you might get from the triplet combination. Does that make sense? Mm-hmm. So at ASCO, my mentor, Dr. Woyak, actually presented the study because it actually had to end early. And the reason why it had to end early was that more patients died on the triplet arm, the ibrutinib, venetoclax, obinutuzumab, than ibrutinib plus obinutuzumab, which we were all surprised about. And ultimately, we had to see how this plays out long-term. COVID was a true impact here. where more patients unfortunately passed away from COVID on the triplet arm. And so if you take out those COVID deaths, it does look very similar. So we'll see how this plays out in the long term. But we were all surprised by that, right? Because we all expected it to, we don't design trials with a new treatment that we don't expect to be better, right? So that's something to remember too, right? We don't design trials that we think are going to fail, right? We always think that they're going to work. And so I think ultimately what this tells us is that, we have to roll our patients onto clinical trials so that way we can get better answers to the questions that we have. And when we enroll patients onto clinical trials, we can follow them forward in time, right, to get the data that we need. So that way, when we have the results, we can then share them with the community at large at presentations like ASCO. And for those of you that don't know what ASCO is, it's the American Society of Clinical Oncology. And it's one of our two main meetings that we have per year. The other one is the American Society of Hematology, which is ASH. So there's ASCO and then there's ASH. And then so we're going to be seeing a lot of exciting things from ASH in a couple of months in December too.
So just to give you a jibe, I mean, every time a patient looks at their blood work on a regular basis, we're inundated with 1,000,001 acronyms, and most of us can never remember what any of those acronyms
fair
state.
enough.
So thank you for explaining what ASCO and ASH were, because I always forget what they stand for.
Yeah.
Dr. Broadway, I'm going to ask you to help us start a conversation by taking a step back. One of the things that was very, very exciting and very, very talked about in the CLL community was the concept, the excitement, the principles behind CAR T cell therapy. Frankly, from a patient standpoint, from my perspective, it was really, really intimidating. It sounded pretty dramatic. What goes on with CAR T? And I would like each of you to offer a little bit of insight.
So basically, CAR T is, we have in our immune system, there are B cells and there are T cells. And the B cells then generally help provide immunity for us. They are immune cells. The T cells are cells that naturally have release cytokines that can kill off things that shouldn't be there. So with the CAR T cell, the principle is that they would take your cells and extract them and send them to a lab, your CLL cells specifically. And then they incubate them with these CAR T cells, which have a natural killer instinct about them, so that the T cells then recognize CLL cells and learn to fight against them. So then they expand these cells in a laboratory setting so that they can get enough of them, and then they give them back to you as similar as to they would with a stem cell with stem cells. They give you the infusion and give you back the CAR Ts. Those cells have been sent to a lab, they've been incubated to cell your cells. And then when they prepare enough of them and expand them well enough, then you're admitted to the hospital and they give them back to you with the hope that then those cells will recognize CLL cells and try and destroy those cells so that helps to rid of CLL in that manner.
Dr. Wierda, this sounds great. There's full-scale war potentially going on in my body, and it's engineered by science. Why aren't we doing this for everybody?
That's a loaded question.
Yeah.
Yes, it is. Tell us why, Bill.
Well, I mean, not everybody can tolerate it very well. There are toxicities associated with the CAR T cell therapy. And if I reflect back on CAR T cell, I've been working in the CAR T cell area for many years. And we have seen data with CAR T in CLL that dates back many years ago. Carl June and his group treated patients with CAR T cells many years ago. And there are patients who probably have been cured by CAR T cells. Several patients, many patients that have been cured with CAR T cell therapy. Not all of them are cured. And the side effect and toxicity profile is difficult for some patients. Patients get sick. It requires a hospitalization. Some patients end up going to the intensive care unit. There are CAR T products that have been approved for ALL, acute lymphoblastic leukemia, and for non-Hodgkin's lymphomas, diffuse large B-cell lymphoma, et cetera. The CAR T work began with CLL years ago. And unfortunately, or fortunately for other diseases, that product has sort of leapfrogged for patients with ALL and for DLBCL. I think that scenario and what's happened there sort of also illustrates some of the challenges. It's not quite as effective in patients with CLL, and there are side effects and toxicities that are probably a bit higher in patients with CLL compared to those other diseases. So while it's sort of the story started with CLL, we're still catching up in CLL. I think we will have a product that's approved. We have worked on the Transcend study, and I anticipate that clearly there are patients who have been in remission, who have probably been cured of their disease, who have failed the targeted therapy with CLL by receiving CAR T-cell therapy, but it's logistically and from a toxicity perspective, it's a little bit harder to work in patients with CLL.
That sounds reasonable. It sounds prudent. I would guess that maybe you're hedging a little bit, that maybe those toxicities are probably a little bit intense. And
yeah,
when you're weighing things for a patient choice, this is a fact. This can have a toxic reaction.
Yeah.
Your thoughts, Dr. Lamanna?
No, I mean, so, we started working on CAR T cells when I was at Memorial it was one of the first studies in that. So this is going back over a decade, 12 years ago. And I think the reason why, in part, it's been slower in CLL is because in those other cancers where it is approved, they had less options of therapy. We've had all these wonderful targeted therapies that have become available. And whether it's fortunate or not fortunate, the CAR T cell sort of got relegated to the multiply relapsed, you've used all your therapies available for your CLL because now we have all these oral targeted agents. And so it's been down here. Now, of course, we've had a lot more experience using CAR T because it's been around now for, as I said, over 10 years. And so I think we've improved upon some of the side effect profiles. But as alluded to, these can have some toxic effects in some individuals. Obviously, in some of the early CAR T cell therapies, clinical trials, there were some patients who passed away from the therapy. So we're learning how to mitigate for some of the toxicity. I think that there's been some very good results from studies such as the Transcend study, which I'll let Adam talk about. And I think we will get an approval. And I think for now, it'll be in the relapse setting for sure. But hopefully, it may move up depending upon as we may use it in combinations for certain particular individuals with the disease. It obviously has some activity in some of our most refractory patients with Richter's syndrome, for example. So patients who have transformed to a more aggressive lymphoma. So there are definitely important uses for CAR T cell. I like to, as we describe it, it's a different type of modality of therapy using your own immune system to attack your CLL cells. So definitely very useful and obviously very successful in other diseases. And so I think that it will move along in CLL and get an approval. It's just that we also have the benefit of having so many other agents. So we'll see ultimately where it fits, in the grand scheme of things. But I think right now in the relapse refractory setting is definitely an important option.
Well, you broke in with, okay, so Dr. Adam, what do you think?
I want to take a step back and just talk about clinical trials for a second because it's important for this. So just to remind everybody, we have like 3 types of clinical trials. We have phase 1 trials, phase 2 trials, and phase 3 trials. So phase 1 trials are usually sometimes first in human or a dose finding. So at the point of a phase 1 trial, they're usually very small, usually under 50 patients, and they're looking for either a dose and safety of the drug. Phase 2 is meant to find the initial efficacy, how well it works. And then phase 3 is usually how a drug gets approved, where you're comparing the new drug or new intervention versus something that we're already doing. And usually that's a much larger phase 3 trial. You're randomized to 2 arms. And the ultimate goal is to find out whether or not the new drug works better than what we're already doing. So I know we've been dropping phase 3 around a lot. And so the reason why I wanted to stop and go through the different phases of clinical trials is because this Transcend study is a phase 2 study. And so it was a single arm study. And it looked at patients who had received BTK inhibitors and BCL2 inhibitors. So that's the ibrutinib, acalabrutinib, zanubrutinib, or the venetoclax. The liso-cel was given, you just get it one time. So usually what happens is you get the blood taken out of you, it gets sent to the manufacturer to make the T cells, and then the T cells get infused back into you. That process takes about 3 weeks. Once the product comes back into the hospital and is available, you get chemoimmunotherapy. And the point of the chemoimmunotherapy is to basically make it easier for your cells not to reject the T cells that you're about to get. You then get the T cells, and it's just that one time. So you just go in the hospital or even outpatient now, you just get the T cells. And then we usually have to follow you pretty closely for 30 days. The liso-cel product happens to be probably the safest of the 3 that are currently approved right now for non-Hodgkin's lymphoma. And certainly we're looking for ways to mitigate the toxicity that's associated with that. And the interesting ways that we're doing that is actually with BTK inhibitors concurrently with the liso-cel. So we're looking at that, giving steroids before, giving various other agents to try to mitigate the toxicity. But for the Transcend study, which accrued about 100 patients, of the patients who actually got the product was only about 80. There were a lot of really good undetectable minimal residual disease responses. And this is where we're going to start talking about UMRD, I imagine. So that means that they weren't able to detect the CLL in these patients. And once again, these patients had been treated with our main lines of therapy. It looked like if you responded to the CAR T cell therapy, you did really well. Unfortunately, there were some non-responders, and that's classic with CAR T cell therapy, is that if you respond, you do really well. And if you don't respond, you don't do so well, which kind of makes sense too. But in general, this was a high-risk group of patients who've received all of our primary lines of therapy with this one-time therapy. There was a really good response rate of about 60%. So really nice data. And hopefully based off this phase 2 study, it gets what we call accelerated approval, which means that you only have approval for a few number of years. The phase 3 study is what gets it full approval, which will come down the line, hopefully.
So Dr. Jackie, we have a question that came in. What do patients find most challenging in tolerating the OV treatment side effects?
I think one of the things that they find challenging is sometimes the immediate effects after getting the obinutuzumab infusion. They may have infusion reactions, and sometimes within the first 72 hours, they may still run a fever. But if they make it through the infusion reactions, which we try to educate the patients very well on so that they're not surprised that they may experience some chills or fevers or changes in blood pressure during the infusion. Secondly, with the venetoclax, the most reported side effects that I've heard is diarrhea primarily. And that is something that we work through with the patient. Although from a provider standpoint, we're looking at toxicity of neutropenia in some cases, not everyone, but there is some degree of neutropenia. So those are the main things that I've heard discussed with patients, particularly with venetoclax. It's a once-a-day dosing. Sometimes they find it challenging to get all 4 tablets in when they reach the full dose capacity for the drug. But the greatest thing has been some GI side effects, primarily loose stools. They are all instructed to, we tell the patients, don't get upset, you prepare for this. We tell them ahead of time there are certain medications such as Imodium AD that they can buy over the counter, or there may be a prescription strength anti-diarrhea med that they may need. So those are the main things so far that some of the side effects or treatment, side effects that they've experienced.
Good information. We're going to keep it casual. Dr. Bill, we've talked about the MABs. We talked about the IBs. Bispecific, a new variant that I have to learn?
Well, I mean, I think it's a different theme on things that we are using. So bispecifics are antibodies which we have used for years in CLL, rituximab being the first one. We have obinutuzumab, which has been mentioned. The monoclonal antibodies are molecules of our immune system that bind to certain proteins. And so what has been done years ago was that they figured out how to make these antibodies in the lab and identify proteins that they could target on CLL cells for therapeutics. So there are proteins on CLL cells that some of the therapeutic monoclonal antibodies we use target. CD20 is one, that's the target for rituximab, for obinutuzumab. Campath, which is a drug that we used years ago, we don't use it anymore, targets CD52. So there are a number of examples of just the naked antibody and therapeutic naked antibodies that target specific proteins on cancer cells, leukemia cells. The bispecifics are an engineered molecule that target some of those proteins, CD20, for example, and also are linked to an antibody that targets a protein on your T cells called CD3. And when you have this sort of joiner molecule, the bispecific that binds CD20 on the CLL cells and CD3 on the T cells of your immune system, when that happens and those two cells come together, the molecule will trigger the T cell to attack the CLL cell and kill the CLL cell. And so the bispecifics are a way to redirect the T cells to eliminate and react and kill the CLL cells. These are drugs that are approved now for non-Hodgkin's lymphoma, but we don't have any approved for CLL yet, but there are a number of clinical trials right now that are studying the bispecifics. Epcoritamab is one of those bispecifics that's already approved, but not for CLL, that's under investigation for patients with relapsed CLL, also for patients with Richter's transformation. And so this is an area or a category of medications that I'm very optimistic about. We have heard preliminary data, phase 1 data, some phase 2 data, demonstrating activity in treating CLL with these compounds. Again, I think there's a little bit more work we need to do in this area as well in terms of optimizing the efficacy and making it a better, well-tolerated treatment for our patients, just like the CAR T cells.
Yeah, because this has more similar side effects to CAR T because of that link to the CD3 or the T cell activation. So it has some side effects that are more similar from that standpoint. So we need to work on that.
This is exciting stuff. I mean, we had a conversation about a year ago in clinic where you gave me a new perspective, Dr. Wierda. You told me that the goal of the staff and the team at MD Anderson was to keep me alive. Because the longer you kept me alive, the better the drugs would be when I needed them. And that was kind of an aha moment for me, because the first drugs that I had to choose from weren't great. I wasn't a big fan of the toxic profile and the side effects and all that stuff. And then I went into one of your clinical trials and I got great results, and we're not even using that drug for CLL anymore. And here we are with, okay, there's pills. There's new monoclonal antibodies. There's continuous treatment. There's fixed duration. We've got a question that came in, and I know we touched on this, but I'd like a little bit more focus. How does one choose between time limited and continuous therapy? And I'll start with you, Dr. Lamanna. Excuse me, Dr. Nicole. We're keeping it casual.
Well, obviously, you know, as Dr. Adams suggested, this can be a very difficult discussion, or not, it's just a lengthy discussion, you know, so we look at disease characteristics, of course, but we're also looking at other factors too. And so, you know, there are sometimes people have medical problems. We'll take into consideration your comorbidities, your heart function, your kidney function. The different drugs, the continuous therapy with the BTK inhibitors have a different side effect profile than, let's say, venetoclax. So these two oral agents that are both very effective. And as said before, we don't know that one is necessarily better than another. And you all heard about the different combinations we're looking at. And so we take into consideration your organ function, patient considerations about, your lifestyle and circumstances about whether or not you want to do something that's time limited and more intense initially, and whether you can, afford to do that and be ever present, particularly in the beginning when there are more side effects with the time limited approach versus a chronic continuous therapy and sort of being on a pill and not having as much follow-up. So part of it is a little bit of the circumstances of the patient themselves, but also the side effects of the drug and what medical problems you may have, what other medications you may be on for these other medical problems, and whether or not there are drug-drug interactions, and how do we overcome some of those issues as well, depending upon the drug. So it winds up being a very large, long conversation, that we go through when we think about all the different aspects about your disease and you yourself and your other medical problems when we talk about your options of therapy. I mean, the good news is now there are all these options. And so it is much more of a conversation because you have a lot of availability of different options which weren't available before. And so, this is a good conversation to have, not a bad conversation.
Excellent. As some of you have noticed, we've had a few questions coming in. I want to encourage each of you that's here in person with us. If you have a question, raise your hand. We'll get a microphone to you. We want you guys to participate in this event as well. There's a lot of stuff that we are throwing at you. And aside from a lot of the words that many of us still have trouble pronouncing, and the fact that there is so much stuff being thrown in, this is good information, and I want to make sure that your questions get answered. We talked about a lot. Dr. Adam, Richter's transformation came up. Patients not being able to tolerate some of these treatments, some trying multiple treatment programs. What happens when we get to the uh-oh stage of this train ride? What happens when, okay, we've tried the IBs, we've tried the MABs, we've tried the combos. The outcome is not looking great. What do we do then? What is next on the horizon?
So I think, so Richter's transformation is an entirely different topic.
Okay.
And we can spend time talking about that for sure. But for standard CLL, I think the area of what we call unmet need is patients who have received our BTK inhibitors and our venetoclax, the BCL2 inhibitors, and have progressive disease after that, or if they're not able to tolerate either of those two medications. And so when I think about what's on the horizon, for one, it's the CAR T cell therapy that we already touched upon. There are also new BTK inhibitors coming out as well, and we could talk about those. And there are new BCL2 inhibitors also coming out. And so I think that as Dr. Bill had said, we are having just an explosion of options for our patients with CLL, and we do expect a lot of these drugs to get approved. And so one of the ones that is as close to approval as you can get is pirtobrutinib, and I expect it to be approved as an accelerated approval literally any day now. Pirtobrutinib is a BTK inhibitor like ibrutinib, acalabrutinib, zanubrutinib that was designed specifically to bind a little bit different to the BTK protein, allowing it to work when the ibrutinib, acalabrutinib, and zanubrutinib stop working. And so the second generation BTK inhibitors are what we call covalent BTK inhibitors, and this is a little deep. And pirtobrutinib binds differently, so it's a non-covalent BTK inhibitor. And now we're starting to call pirtobrutinib our third generation. And they're actually new BTK inhibitors, and we could talk about this a little bit later, but the degraders are coming out. There are covalent / non-covalent BTK inhibitors. So we're now having like 5th and 6th and 4th generation BTK inhibitors, right? So a lot of stuff on the horizon. Pirtobrutinib specifically, as I said, will likely be approved hopefully within the next couple of months. Looks like it's a really safe drug and is an option for patients who are refractory or cannot tolerate those two other medications. So there's always things on the horizon. I would recommend all our patients to look for clinical trials, but we will soon have 2 drugs approved for these patients specifically.
Sounds promising and exciting. I'm in a mode right now of being the general manager of a baseball team. And when you get down to the end of the playoffs, the most important thing you can do is set up your pitching rotation just right. And I kind of timed this because I have a question for Dr. Jackie that came in.
Okay.
Dr. Lamanna hates the term watch and wait. Patience, what do we call it? Watch and worry, right? Yeah, it's not watch and wait, it's watch and worry. We've got cancer. We're supposed to be doing something about this.
That's why I want to change it too. I'm gonna.
Dr. Jackie on the front line dealt with more watch and wait complaints than all three of these folks here. I can remember coming in and you asked me, so how are we feeling today? And I would tell you, I'm fatigued. And you would make me go through the litany of, well, okay, well, what is fatigue? Can you do your normal stuff? Can you do, how bad is it? And we had to figure out what the difference was between just being tired and being fatigued. So we know that watch and worry is a heavy burden that we carry. And no matter what all of you guys say, we're still going to watch and worry. Let's look at fatigue. Is fatigue normal during watch and wait?
Yes, of course, fatigue is normal with CLL in general. So of course, it's normal to have a degree of fatigue as you're watching and determining when there's time to institute therapy. So the thing I always try to reiterate to the patients is when we are trying to make a decision on what is the optimal time to start treatment or if and when you need treatment, it is difficult. It's very hard for a patient to come in and they may have a white blood cell count of 60,000. So in their mind, they think because of the 60,000 CLL, the white blood cell count, that they need to get treated and get rid of it. When in fact, they have a good quality of life. They can go to work. They can still do whatever they want to do. There's this underlying fatigue. So we try to get them to, do things such as exercise and things that may improve the fatigue. And also it's important to find out maybe there are other factors that are contributing to fatigue. So it may not always just be CLL. But we try to encourage them that, we're monitoring everything very, very closely. So there's just no set thing, number at which we decide it's time to treat a patient. So yes, you're gonna have some degree of fatigue, but we try to work through it. Now, when you start having levels of fatigue where you need to go back to bed by 10 o'clock in the morning when you just got up at 8. And, and there are other things, night sweats and other things that are combined, then yeah, maybe that's time when you start, looking at maybe there may be some time to look at treatment options.
So I want to ask a question for all of you here with us today. Raise your hand if you experience fatigue. Okay, good chunk. Okay, raise your hand if you take a nap on a regular basis.
I would like to.
I would like to.
Okay, you would like to. I take a nap. Do you feel better? I want to engage you guys for just a few minutes. Do you feel better when you take the nap? Most of the time?
Yeah.
Some of the time? Cool. One of the things that Dr. Jackie was making sure I understood when I was reporting my fatigue was, one, do I get refreshed from that sleep? Do I get refreshed from that nap? And then more importantly, is my fatigue impacting my ability to do the things that I want to do in life? Those are very important questions to ask yourself, and they're very important answers that you need to give to your medical providers. They need this insight into what's going on with you so that they can help you make good decisions. So we're talking about watch and worry. Not going to call it watch and wait. Dr. Bill, how long do I need to be in watch and wait? I'm in it for a second time. How long do I need to be there?
Until you need treatment. I would like to just maybe make a comment. There's been several clinical trials that have been done to determine whether or not there's survival benefit with early treatment, where you take 100 patients who are newly diagnosed, who don't otherwise need treatment. Half of them get early treatment, half of them don't. That's with chemotherapy-based treatment. It's also with ibrutinib-based therapy. Those trials have not shown a benefit with early treatment versus watch and wait. I think that's very important. We worry, but it's not to the detriment of your survival to wait and to move to treatment when you need treatment. And I think the other thing that helps me with that discussion with patients is our treatments are evolving. What's available today is going to be different than what's available in a year, and it's going to be better in a year.
That's that whole "we're keeping you alive"
The
thing.
treatment improves with time, and you have to have some comfort and confidence in that to sort of, and then as I mentioned earlier today, I'm the professional worrier. You let me do the worrying for you. That's something that's my job, I think.
Now he has said that, and he said it very glibly.
I have to.
He's
No,
the
I'm
professional.
serious about that.
It's not really a joke. All my life, I have been a professional worrier. And we now actually have a little bit of agitation between the two of us, because the week before my regular checkup here at MD Anderson, I get wound up. I absolutely get wound up. I've been doing this for a long time. I know exactly what's going to happen. I know exactly how the blood draws are going to work. I know exactly the rate at which the results are going to start pinging on my phone, so I can get the idea of what's going on. Even though I know all of this, and I know it's more than likely that the answer at the end of my clinic visit is see you in 6 months. Even though I know all of this, I worry, I agitate, I obsess over it. And so one of the things that I do, I kind of mentioned at the beginning that I'm training for a marathon, I pound out more miles. Apparently, you're not supposed to do a half marathon just before a blood draw. And then knowing that you're not supposed to do it a second time. Pro tip, drink more water. Also,
Who is that?
That's
his daughter.
That's my daughter back there. So
Jeff, can I add one more thing?
Oh, please do.
Because you know this is my pet peeve. So, I think if this is truly a chronic illness, although everybody here in this room and on this panel is trying to obviously find curative therapies for CLL. So it truly is a chronic disease that you live with, and we want you guys to, of course, enjoy your life. The reason why I don't like the watch and wait, and I love your term, watch and win. I do active observation and monitoring. That's how I call it. But watch and win's a great one, because as you're sitting on the sidelines, and we're not trying to take away the worry and the concern, of course. But the issue is that all these new therapies come available and it changes the standard of care. And so the folks who are in that watch and wait period or the active observation get the benefit of sitting on the sidelines as new therapies and guidelines and changes that are happening because of all the research that we're doing. And what might have been used 5 years ago may be very different from what's used tomorrow. And that you gain the benefit of that without going through all the pain. So it is an important, if we have a drug that's curative for everybody, albeit there are patients who never need treatment for their CLL, and it would be great if we knew we could draw their blood and knew exactly who they were, because then they would never have to get any therapy or be exposed. But for everybody else, if we had a curative therapy, then we'd be giving it to everybody, of course. So I think that active watch and monitoring of your disease is a very important part to be on the sidelines, and should be reassuring. And also, as I said, we're developing new therapies. The caveat to that too is it doesn't take away the anxiety or the worry, but you need to fill that with other things in your life too, right? Think about if you have other chronic medical problems, high blood pressure, diabetes, heart disease, that you're actively taking medications for. you're just doing something about it every day. Your CLL, if you're not, you're not actually taking a pill. It doesn't mean you don't have the problem. You just don't need any active therapy right now. So I think it's an important distinction. And, I wish people can, think about things a little differently. For those who have other medical problems, maybe it's a little easier because they're used to other problems. But it's just, I think we need to couch it a little differently so patients can deal with it psychologically a little differently.
Dr. Kittai, I know you want to jump into this because the patients are ed up over this. And I want to get your take. And I also want you to take this question number one that came in your practice. What are the thresholds that get people out of watch and win?
Yeah.
I remembered to do it right.
So I want to take a second and just validate all of the symptoms that our patients have on watch and wait. So it's usually these low-level symptoms, and I want to make sure that everyone knows that it is normal to have symptoms on watch and wait. And one of the studies that Bill had mentioned, which was early treatment with ibrutinib, it was early treatment with ibrutinib versus placebo. And what the most surprising thing on this trial for these patients who typically would have been on watch and win was that the patients who were randomized to placebo had a high symptom burden, higher than all of us really expected. And so what I want to say is that it is normal not to feel 100%. And to Dr. Lamanna's point is that viewing this as maybe you may not be getting active treatment that you're taking for your CLL, but in a way you're actively treating yourself because you're delaying the treatment that might be better when you need treatment, right? And so I just wanted to take a second to really validate the symptoms that all of you are feeling, because they are real, and we've actually documented that patients who are randomized to placebo have very real symptoms. Does that make sense? Great. So the question of what are the threshold signs to decide to start treatment? So the symptoms, so there are two types of indications to treat. There are subjective, and those are the symptoms, and objective, and that's laboratory values, big lymph nodes. So the objective ones are a hemoglobin, which is your red blood cells less than 10, or a rapidly dropping hemoglobin, a platelet less than 100, spleen size that is, quote, larger than 6 centimeters below the left costal margin. Basically what they do is they look at your rib, we measure 6 centimeters, and that's that indication. And then the other one is lymph nodes greater than 10 centimeters. Now, these objective indications to treat are pretty big. They're pretty extreme, I would say. And so I typically don't let my patients get up to that level. We typically try to treat like right before, but we see it coming. But you do need to have one of those indications to treat. The other indications to treat are going to be symptoms. And so those are the classic B symptoms that we've been kind of chatting about. So that's fatigue, night sweats, fevers and chills, and weight loss. And usually what I say is that these symptoms typically worsen as the objective signs worsen. So they usually go hand in hand. Sometimes symptoms are at a proportion to objective signs, and objective signs are at a proportion to symptom signs. So sometimes they're a little discordant. Every patient's a little different. And then in order for someone to require treatment based off a symptom, the symptom has to cause so much distress that it causes the patient to have not the ability to enjoy their life, is how I put it. I also don't like my patients to get to that point. I like to try to do it right before they're absolutely miserable, because I don't think that's fair. But those are the classic indications to treat.
Dr. Jackie, question number 2 here. This is important because we've been talking in a very clinical fashion about what's going on with all the new stuff with CLL. I'm going to read this verbatim. I was diagnosed 5 years ago, still in watch and wait. I feel like I'm in limbo. What can I do to just live normally and not think about it ever?
Nothing.
That's fair.
No, I did want to make one point here. When I talk to patients, I know they're worried and concerned.
Mm-hmm.
I think one thing I found that helpful in talking to patients who are in this watch and wait period is I sit down with each of the patients in clinic and I go through their prognostic factors. They need to understand what that FISH test means. So if you tell a patient you have a negative FISH, I mean, they look at you like you have 2 heads. But If you say to them, these are the chromosome abnormalities that we look at for patients with CLL, you have no abnormalities. That's very good. That gives them encouragement. If you tell them when you look at mutational status and other prognostic indicators, if all those things are favorable, I've found that if you just sit and talk with the patient, explain to them, it's unlikely that you're just gonna have this rapid progression of CLL. It doesn't mean they won't ever need treating, but I think that sort of helps allay some of the fears and anxiety that they have. But in reference to the question, the only thing you can do is just go about your life as best you can. Try to focus on other things, your family, and just different things, whatever it takes to keep you busy and keep your mind occupied. The worst thing you can do is sit at home every day, get on Google, stay off of Dr. Google, and some of these CLL blogs, some of them are helpful and some of them are not, because some of them give patients erroneous information. So find a good factual website, use LLS. There are some, Andrew Shaw and others who have had patients say things online that are helpful and factual. And so if you want to hang out with people, at least get in with someone who have the facts and give you the appropriate information. That's pretty much what you can do. Just live life the best you can. I know it's not easy, but get up every day and try to focus on something positive in your life.
I'm going to come back to that in just a second, but I know Dr. Bill has something he wants to add.
Something. So I think part of the challenge with watch and wait or watch and worry or watch and win is that patients feel like they're not doing anything actively for their health. I spend a lot more time in recent years talking about health maintenance because our patients are living oftentimes a normal lifespan. But there are things that are still a normal lifespan as if they didn't have CLL. But oftentimes we struggle with some challenges with the disease, even if they're in remission. And that is the fact that their immune system doesn't work normally. And health maintenance for me falls into two categories. One is prevention for infection. The other is prevention or early detection for other cancers, because we know other cancers occur more frequently in patients with CLL than the general population. So infection prevention means making sure you're up to date on all your vaccinations, the flu shot, COVID vaccination, shingles vaccination. We're talking now about RSV vaccination. So infection prevention is a very important area that patients can actively participate in and make sure that they're up to date. The other is early detection for other cancers. That involves going to dermatologists for regular skin cancer screening, for women, annual mammography, pap smears, for men, PSA, prostate cancer screening, and for both men and women, colon cancer screening. So those are things that you can actively do to assure your health maintenance. And so I oftentimes try to direct the conversation also on that aspect, because those are things that you can do and they are important for our patients.
And I'll add, do the things that your GP wants you to do as well.
Get a GP and make sure.
Take your blood pressure medicine. Take your cholesterol medicine. Keep your diabetes under control. Work on controlling your weight. Exercise a little more often. And when I say exercise, that's my segue. I wanted to circle up with what you were saying about, we worry. So I was taught by a very wise instructor by the name of Philip. He is all about moments and first steps. The hardest way, the hardest thing, the hardest part of starting an exercise program is the first step. The second one's easy. Third one's a piece of cake. Fourth, fifth, and all the rest of them, those are easy. It's when you get up in the morning and know that you need to do whatever it is that you're going to do, it's taking that first step. It's really easy to sit in a chair or sit in the bed and not take that first step. Sometimes all you need is one step, so take that first step. Now, Jackie talked about finding a connection, a something that makes you happy. I encourage each of you, take that first step with your happiness as well. Pick out that one thing, and it doesn't have to be big, but that one thing that gives you the smallest first glimpse of a smile. Indulge me for just a second. I work from home. I have worked from home for well over a quarter of a century. That means that unfortunately the lines blur dramatically between my work life and my personal life. When I hear the email alert go off, I want to go see it. One of the things that I started doing a long time ago happens around 5 o'clock. I stop, I go to the kitchen, I grab a glass, I fill the glass with ice. Doing that means that 2 4-footed furry missiles come flying into our den. I put a little whiskey in that glass. I sit down in my chair and I turn on the evening news. And both cats sit right in front of my lap, waiting for their freeze-dried chicken treat. That makes me smile. That's something that I can focus on. That's something that's worth doing. I'm not focused on my CLL. I'm not focused on a cancer diagnosis. I'm not worried about what my white blood cell count is and what happened to my platelets today and how I sabotaged my glomerular filtration rate by not drinking enough water after exercising. I'm taking those first steps each and every day. We know that watch and wait, I mean, folks, it's not a fun way to live. Dr. Jackie was being candid. What can we do about it? Make active approaches. You can be unhappy, you can be worrying, or you can find that one thing that makes you smile. Or you can go take that one step, and that one step turns into a block, and then that block turns into a half a mile, and then the next thing you know, you're crazy like me, knocking out marathons. Let's talk a little bit more about watch and wait. It's on people's minds. Well, we got a question right here.
So I'd like to go back to the word cure.
Oh, sure. I love this word.
What is cure going to look like when you? Do you want me to repeat it?
Yes.
Okay, I'd like you to go back to the word cure. What is cure going to look like when you think we have a cure? Is it going to be, for example, certainly it's going to be all physical symptoms are good. Normal blood counts. Is it going to be like a clonoSEQ of 0 for 2 years? So I'd just be curious how you're going to know when we're cured.
Ooh, which one of you wants to pick up that hand grenade?
It's going to take a long time. I'll start, I guess. You know, I think that there are probably some patients now who are theoretically cured, that they might have gotten FCR, for example, or some other treatment modality, but their biology of their disease is so good that the disease never comes back. And so they're probably, we don't use the word cure very often, particularly in CLL. And so we don't like to say that because most patients, their disease comes back. But there are patients that I've followed for 20 years whose disease hasn't come back. And so they probably are cured. I think as what you're alluding to is as our technology is improving with how to measure minimal residual disease or these, microscopic CLL cells in your body to different depths of detection, obviously we're employing a lot of these techniques on the current clinical trials to look at depths of detection, and it's changing and evolving. Obviously in CLL, it takes us longer to show if a treatment or a regimen or a combination is going to improve survival and ultimately cure, because we're going to be following some of this testing, which we're doing on the clinical trials. These aren't necessarily mainstream in clinical practice yet, because the mode of detection is changing, and we're trying to put these in combinations with the clinical trials that are running, but we're going to need a long time to show that a particular therapy might be potentially curative. But I'll argue that depending upon someone's biology, there are, in theory, some of those patients already out there. Gentlemen?
You hedged that bet very well.
Did you like that, gentlemen?
Oh, my God.
Go.
I've started using the phrase functionally cured. It's in a sense like, I guess it rephrases the thought process of cure. So if you have somebody who's on continuous therapy and they are not having any toxicities and their blood counts are completely normal, are they cured? I don't know. I'm putting it out there, right? Because they're technically functionally cured. I like to say, hey, I looked at your labs and I wouldn't know you had CLL if I didn't know you had CLL, right? So I guess
Right, and they may still have disease
Yeah.
and die from something else.
Yeah. And they're just chugging along on their BTK inhibitor without side effects, and they're doing great. And isn't that somewhat ideal as well? I mean, we don't like the idea of having to take a pill every day, but to some extent, like if you're not having any side effects and your disease looks like it's really well controlled, I don't know. I just wonder about the word cure, because I think the easiest answer is we don't know the answer to that question, right? Hopefully we get to a point where we have some, we call them biomarkers, which is like a marker that tells us that someone's cured. And hopefully we have that. But I think that hasn't been elucidated yet, even with our most advanced technologies.
So you brought up that marker.
Yeah.
Here we are at UMRD negative. If someone doesn't show any, not a single one of themselves shows up in the count, are they cured?
Yeah, we don't know the answer to that question yet, right? So we think that, so I will say that more and more data is coming out that if we can't detect your CLL, that is associated with a longer progression-free survival and overall survival, right? But we don't know. So, and I'll just take a tangent here just for a hot second, is that another disease type entirely, CML. We know that if you get that patient's CML down to a low enough level, their immune system takes care of it, right? Similar concept with CLL is that maybe our immune systems are able to kick back in and take care of it when we get down to a lower level of detection that we're just not detecting. We don't know. And so I guess that word cure is a tricky one. And of course we're aiming for cure. I'm not saying we're not. It's more of, I hope that one day we have a biomarker that securely says like this patient will not have relapse of their CLL again, and they don't need to be on a medication, and they are not more immunocompromised than the general population.
So we have a question that came up here that I want to direct to you, Dr. Bill. I want to try to do my take on what this question is asking. You encourage people to do watchful waiting, watch and win, careful surveillance, let you do the worrying. Patients are on watch and wait for an extended period of time. Now, in general, people with CLL are considered to be immunocompromised, correct?
Correct.
So the longer they're on watch and wait, the longer their immunocompromised bodies are exposed to the world versus go ahead and start treatment and get me unimmunocompromised. How do you balance that ledger?
I think probably the challenge here is that you're assuming that being in remission and even undetectable MRD assures your immune system is back to normal.
Ooh,
But we haven't seen that. We've done a lot of trials and have many patients who are still immunocompromised, even though they have undetectable MRD status. So it takes a long time for the immune system to recover and to restore normal function. And our work in the future at Anderson will be dedicated to figuring out what are things that we can do to accelerate restoration of the immune function and the immune system. But right now, we don't see that everybody's immune system is totally normal even when they're in remission and they're undetectable by MRD6 for CLL.
And there's like a lot of heterogeneity in terms of all of you with your immune system. There are some people that their immune system is not as compromised as another person. And so, again, I think we're learning about how to sort of figure out or which individuals might have a worsened immune system based on your disease versus somebody else, because there are some CLL patients who never get sick. And there are patients who get sick all the time. And that's whether you're on watch and wait or on active treatment. And so I think there's a lot that we need to learn in, as Bill said, in restoration and understanding, the heterogeneity in our CLL patient population, that you're all different and not everybody is as immunocompromised as the next person. And then how on therapies and or off therapies, even to sort of identify those individuals and find out if there's ways that we can help with to augment their immune system. And there are trials looking at vaccines in CLL patients. There are trials looking at immunoglobulin in CLL patients to see whether or not they benefit, and how we look at decreasing incidence of infection. So there's a lot of ancillary work besides treating the disease itself to see, how we can make things better for patients with CLL in terms of their immune system. Stay tuned.
I know you've got something to add, but I want to point out, folks, have you gotten a load of his socks over here? I mean, these are awesome. I mean, bravo. Well done, sir.
I tried. Yeah, is this why you said that? Is that why?
Okay, so mine are a little subtle as well. Yes.
Bill's like, we'll work on that.
That's standard. I mean, what would you like to add about the watch and wait? I know that this is something that we have to talk about all the time, because we have patients and their caregivers in here. Some of them are vets. I mean, they've been at this for a while, and some of them are new, and this is just overwhelming to them. Convince the new people that you've got this.
That I have what?
You can take care of their watch and wait.
Yes. So one thing that I'll add is that a lot of questions I get often is, how long will I be in watch and wait?
Yep.
That's a question I get a lot. And there was one study that looked at 3 different factors. They looked at IGHV unmutated versus mutated status. They looked at, can you feel lymph nodes, so palpable lymphadenopathy, and a absolute lymphocyte count greater than 15. So when they looked at these 3 factors, and they looked at if you had 1, 2, or 3 of these factors, how long would I be in watch and wait for? If you had 3 factors, typically it was around 2 years. If you had 2 or 1 factors, it was 2 to 5 years. And if you had no factors, it was greater than 5 years. Honestly, a lot of people buck this trend, but at least it gives us an idea of what to expect. And I hope that everyone bucks the trend, but at least it's something that we can look at and at least advise our patients that, like, yeah, if you have all 3 of these factors, most likely we'll need treatment sometime in the next 2 years. And if you have none of those factors, like really over 5 years is a time that you'll probably be in watch and wait. One thing that we look at in, I know Dr. Jackie had mentioned this, was the prognostic factors that we look at for our patients with CLL. So there's a grab bag of factors. There's IGHV mutated status. There's FISH, which stands for fluorescent in situ hybridization. There's cytogenetics, which kind of measures the same thing as FISH. And then there's next-gen sequencing. So how I envision this is that they are different tests that look at different parts of the cancer's genetics to tell us how high risk the patient is. IGHV mutated status is, how do I explain this? So what this is our normal cells, our normal white blood cells, they get programmed, they go through this, hypermutation where they get programmed to attack the very specific bacteria or virus, okay? What we found is that if the CLL cell comes from the pre-program or after the program, actually determines prognosis, which is interesting. And so if it comes pre-program, that's IGHV unmutated. And if it goes after program, then it's IGHV mutated. And mutated is generally considered a favorable prognostic factor. So we look at all of these things together and help our patients understand what their prognosis will be. But a lot of that's also changing with our new therapies, where some of the things that we thought were important are no longer important. And some of the things that weren't important are becoming more important. And your physician will help guide you about what your risk factors are in terms of what to expect for your prognosis.
Dr. Jackie,
Yes,
Do patients confide in you? Do they tell you the truth?
they do. Oftentimes they will tell me or the advanced practice providers things that they don't really want to share with the doctor for whatever reason. But yeah, I think that, you know, whenever I ask them, they are very truthful. And I also wanted to tag on to what Dr. Wierda said as far as the immune system being intact or not intact. I can think of several patients now in our clinic who are in remission, and yet they still have all these infections and so forth. And so we're giving them IV infusions of gamma globulin to try to, you know, boost the immune system. So being in remission definitely does not indicate that you have an intact immune system right away. At some point it may. But yeah, I think the patients are very truthful and forthcoming with information when I speak with them.
It has been my experience, because I am male, that we really don't give you as much information as you would like to receive.
Me?
Yeah. It's a very common situation in clinic where you're asked, so how are we doing? And us dudes say, doing good, doing fine. And the significant other is doing the,
That's true.
and there's a laundry list of things that's going on that I'm doing fine doesn't quite cover. So this is the point where I advocate on behalf of all of the medical providers here. When you're in watch and wait, nothing is off the table. Everything must be on the table. Do not dismiss anything as being too trivial to discuss, because everything is important. They need to know what's going on. When I had night sweats ages ago, it had nothing to do with the Thai food that I loved. It was an important thing to communicate. We've got a question over here. Let's get a microphone to you. Hang on just a second. It's coming, I promise.
Thank you very much. Dr. Wierda, you brought up on this immune system, because CLL, very effective on the immune system. We've done the COVID, the flu, the pneumonia. We've done all those good things. But there's been one question that was raised, was the shingles you brought up. Is shingles okay with CLL?
To get the shingles vaccine, so you should not get the live virus vaccination for shingles. The one that's used most commonly now is not a live virus, it's Shingrix. It's 2 doses Shingrix. 2 doses separated by 2 to 6 months. So you get 1 dose, and then 2 to 6 months later, you get a second dose. That's all you need to do. And it's not a live virus. You should not get live virus vaccinations if you have CLL, but Shingrix is not.
I think they took the first one off the market.
Yeah,
So I don't think it's on the market anymore. Yeah, we can.
Let's get the microphone over here. We have one more question. No, we had several questions, actually. Let's do this.
Actually, I hadn't heard the fish test mentioned until the last 5 minutes, but 10 years ago, to me, that seemed to be a big deal. And if one had 17P, you know, you didn't have much time left. Is 17P any worse than anything else now?
Yeah, so 17P is still one of our most important prognostic tests. And so patients with 17P, and that's on fish. So the classic fish testing that we do is deletion 13Q, which is a good prognostic factor, okay? Deletion 11Q, which used to be a bad one, but now seems not to matter as much anymore. Trisomy 12, which is intermediate, and deletion 17P. So patients who had deletion 17P on fish, we knew did not respond well to chemotherapy. Now that we have the new agents, our new agents work in patients with 17P. It still does matter, as it does appear that patients with time-limited therapy, it's one of the decisions that we have to make. In general, we favor continuous therapy for patients with deletion 17p. Not to say that you can't get time limit therapy with 17p, but it appears that 17p may matter more with time limit therapy than it does with continuous therapy. So yeah, 17p we definitely still pay attention to. And then 17p typically goes along with something called TP53, which is done on that next generation sequencing, that other level of test. They usually go hand in hand. Sometimes they can be discordant. It's the same thing pretty much. Great question.
So I guess the patients where they had these features that were considered more adverse or worse, these new targeted therapies have done great for those individuals too. So it's still important because in the clinical trials, what we're trying to do is see when we talk about these combinations, these doublets and triplets and orals, we're trying to see for the higher risk individuals, whether or not perhaps when we talk about personalizing treatment and tailoring therapies for different individuals with CLL, the question is, are some of these alternative strategies with combinations, will they be better in more high risk disease individuals versus non-high risk disease individuals? And how do we tailor our therapies better depending upon the features of your disease? So stay tuned for more about that as we get more data from these clinical trials. But the patients with 17p and P53 are doing so much better on these targeted therapies. So they're still important, but compared to the chemoimmunotherapy days, obviously folks are doing much, much better because of these targeted therapies.
My friend Brad has a question. He needs a microphone. Here it comes.
What is your consensus on the RSV vaccine? It seems like there's been some differences of opinion. I know, Dr. Wierda, you told me it's got a short effectiveness. So what's the consensus here?
So I'll start. I don't think there's a consensus yet.
Right.
So it's a new
Agreed.
vaccination. We heard a little bit of data at the International Working Group for CLL meeting that we just had in Boston. So I think we need more data around its effectiveness in patients with CLL, its utility in CLL. I don't see a lot of drawbacks of giving it. So, but we haven't entered an era where we're recommending it for every patient like we do for the flu shot yet. That may come, but because it's a new vaccination and there's limited data in the general population, there's really not any data available for us in the CLL community.
Agreed. And just a more global comment about vaccines, because this came up in some of the questions earlier as well. When we think about vaccines, because, we're trying to, how do we mitigate for the infectious complications, whether they're bacterial or viral in patients with CLL? And we know that in general, many CLL patients, that your all's immune system is impaired. And so your ability to mount the same type of antibody response to some vaccines compared to patients without CLL is generally diminished, is not as good. That doesn't mean you shouldn't get them. If the point is that you can get the flu shot and still get the flu, you can get the COVID vaccine and still get COVID. But if it diminishes the severity of those illnesses and prevents hospitalizations, that's what we're trying to do, right? We're trying to give you all any armamentarium that you might have to protect yourself from bacterial or viral infections that are running around, so you're not as sick. Because one of the number one complications we see in CLL patients, and many of you know this in the room, infection, right? So pneumonia, sinusitis, cellulitis, hospitalizations. So despite complications and things that we're talking about, side effects of therapy, the other big thing we deal with is really infections, and you guys all deal with this. And so, that really inhibits people's quality of life and recurrent hospitalizations. And we have many patients who go through this day in and day out. So anything we can use to utilize and diminish those infections, we're trying. So even though we understand that, vaccines may not be perfect, we still recommend COVID, because that was one of the questions that came up on the screen before is, well, despite all the potential side effects of COVID vaccine, should I not get them? No, you should get them. Because we lived through 2020. We saw how bad it was. We saw how many people died. And CLL patients had one of the highest mortalities or morbidity due to COVID. So even though there are, we know, risk-benefit ratios for everything you do in life, including side effects potentially from some vaccines, we don't want you guys getting sick and admitted in the hospital due to these infections.
So Dr. Kittai, I'm going to drop a bomb in your lap. Dr. Lamanna has already addressed this on one of our Facebook support groups.
What did I do?
but it is a persistent belief.
Oh, yes.
I
did
know
drop a
the
bomb. That's
answer
right.
to this question, but I need for this to be reinforced in our community
Thank you.
because it is a pervasive
Yep.
belief. There are a large number of CLL patients that believe the COVID vaccine gave them CLL. Seriously. Can you talk about what's going on there? Why do they think this?
I will just say that there's no data to state that COVID gave patients CLL.
What about the vaccine?
Sorry, the COVID vaccine
Okay.
gave patients CLL. It honestly is, I think it comes back to the statement that Dr. Nicole had made, is that, you know, a lot of people think that they get the flu vaccine and then they get the flu. And so ultimately, you know, when COVID was first happening, you know, we were recommending our older patients to get the COVID vaccine, right? And so you can think that, you know, given that CLL is a disease of older patients, there's going to be a chance that any older patient might develop CLL at any given time. And so it may have also been that someone may not have seen the doctor for a while and then got COVID, then went to go see the doctor and finally had labs. Remember that CLL is usually diagnosed incidentally, so it just might be timing, but there is no evidence that the COVID vaccine causes CLL.
Thank you for that. We are slightly ahead of schedule right now. I'm going to let everybody know here that we're going to have lunch in just a moment. We're going to give the folks in our virtual audience an opportunity to grab a bite to eat as well. I thank everybody for all the great questions that are coming in, both in person and online. Doctors, we got a little casual. It's working great. I like this. This is good stuff. We are going to reconvene precisely at 12:30 Central Time. So this is a good time to take a break. Thank you, and we will see you soon.
you.